Undertaking a 10-minute headache presentation is not easy, and hopefully in these next number of slides I'm going to offer you some tips to facilitate this consultation. I want to look at two cases. First of all is a new case of headache in a young person who's well. The second case is a more challenging case. It's a complex multimorbid problem, a long history of headache, not sleeping, no clear features to offer a clear diagnosis, pains all over, abdominal pain, muscle pains, already has a history of anxiety and depression, and an ongoing concern that this could possibly be a tumour. So here are the two cases, and we have a very different approach to both of them. In the first case, the new headache, we need to make a diagnosis, exclude a serious secondary pathology, offer a simple explanation, and treat appropriately. In the complex headache case, we need to unpack a complex problem, offer a coherent story that makes sense to the patient, and manage the problem more holistically, utilising not only the best that medicine can offer, but also the body's intrinsic ability to heal itself. And this sits within the context of a therapeutic consultation. So let's start with case one, the simple and new presentation. So step one, don't panic. Headache is straightforward. It's not rocket science, but it takes a little bit of understanding with what's going on. And the first step is to think about what you are going to make a diagnosis, what framework you're going to use. And this is the International Headache Society classification of headache, which is our starting point. Headache was first classified in 1988, and we're now into our third revision. And headache is classified into secondary headache. This will be from the perspective of general practice, less than 5% of things you see. A secondary headache is when there's an underlying pathology that can be readily identified. Primary headache is by far the most common headache, over 95% in primary care. The most problematic would be migraine. Tension type headache is the most common in the population. And then this group of autonomic cephalopathies, of which cluster is by far the most common. I'm not going to say anything more about tension type headache, because I think if tension type headache is bad enough to come and seek help from a medical practitioner, it's far more likely to be as part of a migraine spectrum. It's a bit of a controversial area, but many people would put tension type headache on a migraine spectrum. And if you look hard enough, you will find elements of migraine. And in fact, I think I've only made a diagnosis of tension type headache about 2 or 3 times in my career. So that's where we start from. Which takes us to step 2, which is apply Bayesian statistics. This is looking at pre-probabilities. And here's a simple rule of thumb you might like to start with. If they're under 50, ask yourself, why is this not migraine? Migraine is by far the most common presentation in all clinical settings. If they're over 50, new migraine does occur over 50, but I think the important question to ask yourself in this age group is, why is this not temporal arteritis? So let's look at a simple probabilistic distribution. Migraine, by far, this is from the perspective of primary care. Migraine is by far the most common diagnosis, followed by cluster headache, temporal arteritis, and then small frequencies of other problems, which are obviously far more serious, subarachnoid hemorrhage, tumour, and other secondary headaches that we won't expand in any more detail at this stage. Step 3, take a history. And I think the important thing to stress here is all headache diagnosis is in the history. It's very rare that, I think you have to examine the patient, obviously, but it's very rare that examination will change your management. And again, I'm not going to go into any detail in history taking, but I think these are probably 5 questions that are fairly key, and I think I'd put fairly high at the top of my list. I'm always after a family history of headache. If there's a history of headache in the family, it's very likely to be migraine. Problematic headache will be migraine. They might not have actually known it as such. And if there's a family history of problematic migraine, there's a high likelihood that you're looking at migraine in front of you. It's always useful to know the length of history. If the headache's been around for some time, you can be slightly more relaxed as with a new headache than with a new headache. we're always after progression as a worrying sign. Are things getting more frequent or more severe? The length of headache, the amount of time you get headache for, and any associated features are an important diagnostic pointer. And a simple question really is to ask someone, what do they actually do when they get headache? If they get cluster headache, they pace the floor, they bang their head against the wall, they're agitated. With migraine, they want to pull the curtains, turn the telly down, lie quietly in a darkened room if they can. So those are just some important features of the history that you may like to think about. Step 4 is a basic examination, and if they're over 50, I think it's mandatory to take inflammatory markers because it's very easy to miss temporal arteritis. And what about the basic examination? Well, I think there's two things you need to do. Ophthalmoscopy is an absolute bare minimum. And I think it's useful to take the person's blood pressure. They may have had it done recently, or they may be on top of their blood pressure, but I think it's good practice, and the patient likes having their blood pressure taken. In fact, the relationship between mild and moderate blood pressure raising and headache is contested. They may possibly have malignant hypertension, very rarely. But I think these are the two key starting points for your first appointment. Many GPs won't be confident about looking at fundi. You can always send them to the ophthalmologists, the opticians, to get a proper assessment, although many patients will actually have to pay for this. So when you've done that, taken the history, done a very basic examination, you are now in a position to move to step 5. And we are looking now as to whether you will be pressing a red button, do something right now, or pressing an orange button in the first instance, do something quite soon within the next week or so. So where are we with our red buttons? Act right now. 3 things we really need to focus on: papilledema, thunderclap headache, and any new headache over the age of 50. So papilledema, something is blocking. The most common cause is something is blocking the flow of CSF. And I don't think we're looking for nuances as GPs in disc margins. We're looking for fairly gross papilledema, which indeed I must say I've never seen. Probably I've missed it, but I've never actually flagged it up. But anything you're not sure about, ask your local opticians to have a look at. Most causes of raised pressure are caused by something blocking this circulation, but we need to be mindful of the problem of idiopathic intracranial hypertension. We're not quite sure what causes this. Is it too much production of CSF? Is there not enough reabsorption? We don't know. Usually we find this in overweight females. It can be associated with visual disturbances, particularly visual field disturbances. Acuity disturbances can be associated with tinnitus. And the problem here is if you're not on top of this very quickly, they can lose their sight. So that's papilledema. Thunderclap headache is an important cause of a red button headache. This is a headache which is very severe, usually the worst headache they've ever had. Feels like they've been knocked on the back of the head with a baseball bat, rising to its maximum crescendo in 1 minute. Here are all the possible causes of thunderclap headache. At this stage, you needn't be too concerned with making a diagnosis, you just need to get them in. However, there is a subsection to step 5 with thunderclap presentations, because in many instances they will be seen in casualty. They will have a normal CAT scan, they may or may not have a normal lumbar puncture, and they would be sent out without a diagnosis. You will probably want to refer them to a neurologist if things aren't very satisfactory, and then they'll have to wait a year or 2 to see a neurologist. So you may be in a position where you need to start thinking about making a diagnosis yourself. So I've set the presentations of thunderclap headache into 3 sections. The first section will have been excluded by a CT in casualty. The second section, we're always on the lookout for people with lax joints, part of the Ehlers-Danlos spectrum. They have poorly supported connective tissues, and they may be, quite rarely, but it may happen in these people, cervical artery dissection. There can certainly be spontaneous intracranial hypotension, The dura can, often a fistula in the dura can rupture as it's not well supported by collagen. They may have acute cervical instability as their presentation. So one question you can certainly ask when you're presented with these people when they've had their normal CT scan is, do you have lax joints? And the other thing you need to think about is a condition that not many people have heard about outside the headache world, and that is a reversible cerebrovasoconstriction syndrome. And I think two questions here that can be quite useful are, have you ever had sex headache? We now know that most of sex headache is caused by this condition, and this condition is also exacerbated by vasoconstrictive drugs, of which the most common will be SSRIs or recreational drugs such as cannabis or cocaine. So what is reversible vasoconstriction syndrome? Well, you can see this constriction in the cerebral arteries. This can lead to problems of stroke. You will need an angiogram for diagnosis. This is unlikely to show up on imaging. The other difficult thing is that constriction, for some reason we don't quite understand why, may not be immediate. You can have the pain and the constriction follows some time afterwards, and the pain can last up to 3 months. So you need to have a fairly high level of suspicion for this condition, but it is something you need to have in the back of your mind. New headache over 50, we're always on the lookout for temporal arteritis. And I think here the first thing you must do is take a blood test. You may wish to refer them if you have a high level of suspicion. Just follow the local guidelines, because these may vary considerably depending on whether the investigation of choice is ultrasound, when steroids can impact upon the accuracy of this test, or if they are taking biopsies in your area, then you can give them steroids when you see them, which will not affect the histology for a week or two. So I think anyone over 50 is a red button in that you need to do something, even if it's only to take an inflammatory marker blood test. There are some other red buttons: acute glaucoma, malignant hypertension, meningitis, meningoencephalitis, and another one to have just in the back of your mind is carbon monoxide poisoning. Still kills about 5 to 10 people a year. So those are the red buttons. Let's move on to the orange buttons. Do something soon. And here we're looking at, I think, two main presentations. Is this a tumour? And the second thing I think is also a orange button is cluster headache. I think you need to do something soon with cluster headache. It happens very rarely that things are tended to quite so soon, but it is arguably the most painful condition known to medicine, and I think you need to be on it pretty quickly. Headache and tumour, 70% of people will get headache at some part of their tumour history. 50% of people will have headache at presentation, but isolated headache, that's headache alone without any accompanying signs or symptoms, is actually quite reassuringly rare. Only about 10% of people will present with isolated headache. And these are the sort of things we're looking for. These are things that are approximately over 1% risk, and you need to be imaging. Headache with an abnormal neurological signs or symptoms, new seizure, headache triggered by exertion, that's about a 10% risk of an underlying tumour. History of cancer elsewhere, particularly prostate and lung and breast, HIV. Then there is this difficult group of orange flags where the presentation is likely to have an underlying risk of tumour of between 0.1 and 1%. These are, you can certainly image them, and as we're becoming less risk averse, we are imaging more frequently, or you can watch them closely. Anything that raises intracranial pressure that gives you headache that shifts very significantly in character, and that's always a difficult call to make, because migraine indeed shifts, comes and goes, waxes and wanes, gets different features, but we're looking at significant shift in character. Headache that awakes from sleep due to the concern with raised intracranial pressure, although having said that, cluster and migraine will wake from sleep. We've mentioned headache over the age of 50, and then these subtle memory loss, personality changes. So you have a fairly low threshold for investigating the latter two, but these are things you can either image or watch closely. I just want to put this x-ray up. It's one of my favorite x-rays. This is a case of cluster headache. This is a plain x-ray of shotgun pellets in someone with cluster headache that took a shotgun to themselves. Cluster headache, suicide headache. That's why I would like to suggest this is placed in the category of orange buttons. So step 6, I'm not very sure what's going on here. What do you do next? Excuse me. Well, the first thing is a delaying tactic. You're waiting, looking for a pattern to emerge. Keep a diary, safety net. See you again in 6 weeks' time. Step 7, 4 weeks later, they come back and you're still not sure. Delaying tactic number 2. Basic neurological examination, basic blood tests. Just do the routine bloods, no other specific blood tests unless clinically indicated is an important point. We don't do cardiolipins or antiphospholipid antibodies. Continue the diary, reassure that you don't think there's anything serious, but you'd like to see them again in 4 weeks' time. And if you want a quick neurological examination, there's a very good examination here on YouTube by our colleague Giles Ellerington, which takes 3 minutes. 8 weeks, they come back at step 8, still not sure. You repeat the neurological examination, you discuss imaging, bearing in mind that there will be a frequency of incidental abnormalities of up to 15%, which can cause considerable anxiety. And at this stage, you could consider advice or referral. So that, in a nutshell, is our first case, a first presentation of headache done in a maximum of 3 10-minute consultations. What about our case 2, our sort of this, in many cases, a heart sink? And as I've alluded to, the whole focus of our management shifts. First of all, we need to be aware of other causes of chronic headache. Here they are. I'm not going to go into them in any detail because with a presentation like this, it's about 99% likely to be chronic migraine. It used to be called transform migraine, which I think is a much better term for it. Because you can see what tends to happen. Episodic migraine builds up over time with increasing psychological and social stressors. As with build-up of headache frequency becomes build-up of disability, relative ineffectiveness of treatments, a lot of medication overuse headache, a lot of comorbidities start to occur. So I think the guiding principle here is to negotiate the interface between medical science and the body's intrinsic ability to heal itself, this concept of healing. So step 1. Listen to their story and take them seriously, witnessing their suffering. This is hugely therapeutic. No one will have listened to them before. They would have been pushed around from pillar to post. Just to listen to them and take them seriously is hugely therapeutic. Step 2, let's get the basics done. Take a history, and there's 2 real key questions here. How many types of headache do you get? I think a lot of people get confused by patients presenting with numbers of types of headache. There will usually be a migrainous feature somewhere. There will usually be a background dull, if you want to call it a tension type headache or a migraine spectrum tension type headache. Often they will get idiopathic stubbing headache. There will invariably be a complication from medication overuse headache. So at the first glance, you might think, what on earth's going on here? Until you ask them how many types of headache do they get. They can unpack this. One of them will be migraine, and you can confidently make a diagnosis of chronic migraine. Do your basic examination, 3 minutes maximum, reassure about serious pathology and reassure about the fact they don't need a scan, and then you can do some basic blood. So I think that's a reasonable first step. Step 3 is to establish realistic expectations. So what you're going to offer them is an understanding with what's going on, a coherent story. We're looking for control, not cure. It's not going to happen overnight. We're going to take some time to sort out. And it's going to need commitment from both you and the patient to move them forward. Now, clearly this isn't going to happen within the constraints of a 10-minute consultation, so you can ask them to come back for a double appointment, or you can do this in a number of 10-minute slots. Step 4, we can start them on appropriate medication management. We'll be seeing much more of this as the day goes on. We can address their medication overuse component. Step 5, let's get the multimorbidities out on the table. Migraine is highly multimorbid. There are many of them. Here are the most important ones. You're probably aware of the fact that they have anxiety and depression, highly comorbid with migraine. They're on antidepressants already. There are other problems that you may not be aware of the relationship with migraine. You just need to ask about these, in particular insomnia and often restless leg syndrome, which exacerbates the insomnia. There are diseases that will be more comorbid that hopefully you will be already aware of and previously diagnosed. There will be life traumatic events, and in particular significant childhood adverse events, and unless you address these, they will not move forward adequately. I know it's a bit of a controversial area, but virtually everyone with chronic migraine will have a chronic or a sort of significant life trauma somewhere, and the majority of these people will have childhood significant adverse events. Migraine is actually comorbid with neurodiversity, but you may not wish to go there at this stage. Step 6, offer them a story that makes sense. People with migraine have hypervigilant, hypersensitive brains, which was an evolutionary advantage when we were evolving on the plains of Africa. If you could spot the lion that was after you, or if you could spot your lunch in the long grass, then it was an evolutionary advantage to you. Fast forward a million years and you can see now how a migraine type brain is not conducive to your well-being. Step 7, we started them on medical treatment. We now need to start thinking holistically. Holos, what does holos mean? Well, it's the Greek word, takes its root in the Greek word whole. And I'd like to suggest that healing is creating a context for the body's intrinsic ability to regain its normal function alongside appropriate medical interventions. And you don't have to look very far to see healing in action. Here we see the active against placebo rates for some of the important trials with the new group of drugs, Gepants, which have made a very significant impact on people's lives, and we'll be hearing quite a lot about these as the day goes on. And you can see that placebo rates are very significant. Now, what we tend to do is say, isn't this great, the results are significant and the placebo is pushed under the counter, rather than asking ourselves, what's going on here? And how can we utilize this to the benefit of our patients? It's an area of increasing interest to me, this concept of healing. And there are three key theoretical concepts. I'm just going to flag them up here now. First of all, this concept of allostatic control rather than homeostatic control. So the brain is a predictive organ, a feed-forward organ rather than a feedback organ. The brain and body are viewed best as one complex unit. This is the construct of embodiment or multi-scale architecture. But from a practical perspective, this concept of allostatic load, stressors, physical, psychological and social, lead to a chronic inflammatory load, which then reduces the migraine threshold, impacts upon the brain's cognitive ability and in particular its predictive ability, leading to the problems that we see in migraine. So here's the simple picture for the story for our patients. They have a number of stressors in life which cause chronic inflammation. Migraine itself is a stressor. Migraine is an inflammatory condition, and many other areas of life are also chronic inflammatory conditions. And I like to think of this as filling our stress buckets. We all carry our stress buckets around, and as these become too full, they overspill and impact upon our cognitive and control functions. This load is held in the body. The body keeps the score. And this in turn feeds back on our body control mechanisms, which exacerbates our migraine, leads to more psychological and social problems, and the whole thing takes off in a glorious positive feedback loop. If you want to know a little bit more about this is perhaps something for another rainy day, I would direct you to the works of Carl Friston and Michael Levin, which gets quite theoretical quite quickly, but is really very interesting. From a practical perspective, what can we do? Well, I'm putting together this project called Manage Your Migraine Holistically. It's got a little bit out of control, but it's almost there. The website is up and running, but not actually yet loaded. And it will be ready in about 4 or 5 weeks' time. And it's a handbook identifying all the things you can do for migraine, explaining everything, lots of cartoons, and it comprises of 4 columns underpinned by 1 framework, and it's associated by a number of online PowerPoint talks that I have done, and the whole thing is going to be free to be downloaded. And the 4 columns are the medical approach. Do I have the best evidence-based medical treatment? Is my external environment optimal, beneficial to my migraine health? Am I supporting my body to heal itself? This is all about managing the internal environment, mind-body approaches, breathing approaches, other complementary approaches. And finally, managing the interaction between internal and an external environment. How can I improve the harmony between my inner and outer worlds? Interesting to note that one of the ancient Chinese perspectives on health, they defined health as a dynamic harmony of inner and outer worlds. So that pushes out the boundaries a little bit. We talk about things like nature immersion and the importance of social engagement, but this is all underpinned in an appendix by some quite solid theoretical considerations, underpinned by reframing the sense of self. People with chronic migraine are angry, frustrated, bitter, guilty, and they need to renegotiate who they are. And we draw upon insights often taken from, again, Eastern philosophy, particularly Buddhism, of self-compassion, value-based therapy. This is all becoming very much mainstream NHS stuff. So that's the package. So when you've offered them all that, when you've been through all that, you can sit back for final step 7 and feel grateful that you've been able to reduce someone's unnecessary suffering very significantly. Just like to finish off with some resources. This is a website that our GP with a special interest or extended role for the British Association of Study of Headache have just got together, and we're just beginning to put stuff on it now. There's a whole range of resources for different types of people. Support for primary care practitioners is where you will find some stuff that's useful to you, so you may like to have a look at that. So hopefully you've taken away some useful tips from that, and I will finish there.